Postpartum hemorrhage, or PPH, is defined as greater than 500 milliliter estimated blood loss in a vaginal delivery or greater than 1,000 milliliter estimated blood loss at the time of cesarean delivery. PPH is the leading cause of maternal mortality and morbidity worldwide and accounts for nearly 1/4 of all maternal pregnancy-related deaths. It is imperative that nurses are capable of making prompt and effective interventions for the prevention and treatment of PPH. Uterotonics are usually the first line of medication administered, but we wondered if there were any effective non-pharmacological interventions in preventing or treating PPH. We formulated the PPH question. In laboring mothers, does uterotonic agents compared to non-pharmaceutical approaches impact the incidence of postpartum hemorrhage? In our research, we found a number of studies that used a standardized method such as prevention protocol and education to reduce the incidence of PPH. Brew et al. Did a study where they trained staff with sessions of realistic scenarios and debriefing. Results showed a 47% drop in whole blood transfusion rates after the training. In another study, Fulton et al. Assessed the effectiveness of comprehensive protocols for treating PPH and found that it resulted in reduced blood transfusions and hysterectomy, which in turn reduced maternal morbidity. We also saw the effectiveness of hemorrhage risk assessments to prevent maternal morbidity in a cohort analysis done by Madzie and Homa, where early identification of high-risk patients would lead to better outcomes. Another non-pharmaceutical intervention for PPH was flexible sacrum positions. Wang et al. Performed research with randomized controlled trials studying the effects of the flexible sacrum position and found that it promoted maternal well-being during childbirth. Lastly, we found a study by Galis et al. Researching which uterotonic medication was the most effective in preventing PPH. They concluded that ergometrine plus oxytocin combination, carbetocin, and misoprostol were more effective in preventing postpartum hemorrhage than oxytocin alone. Our group came up with these 4 clinical guidelines. Standardized methods to address maternal hemorrhage should be put into place at every hospital. Hemorrhage risk assessments should be conducted on every laboring mother to assess her risk of PPH in order to initiate early preparations and interventions. Certain non-pharmacological measures such as flexible sacrum positions, back massage, mother-infant skin-to-skin, and acupressure promote maternal well-being during childbirth and should be encouraged. Prophylactic administration of ergometrine plus oxytocin combination, carbetocin, and misoprostol plus oxytocin should be administered per consent of laboring mother and according to hospital policy to minimize blood loss. In conclusion, more data collection and analysis should be conducted to gain a better understanding of the effectiveness of non-pharmacological measures in preventing PPH. With this limited data, it cannot yet be determined if uterotonic agents are more effective at decreasing the incidence of postpartum hemorrhage in comparison to non-pharmaceutical approaches.